Hey everybody, and welcome back to the latest episode of Code Brew. This is Joe King, and I'm here with my co-host Lukewarm.
Hi everybody.
So we're on episode 6. Really excited to be experiencing this movement and getting content out here, and never really thought we'd. Well, I wouldn't say that. We did think that we would have some success, but we're definitely.
Episode 6 seems weird.
It does. Like we're really enjoying this process, and all the, like I said, we've gotten pretty much all positive feedback up to this point, I think, and it's really exciting, and that's all because of y'all being a part of this and giving us that feedback and interacting with us. So you're very appreciated. We have had a very, not you. You're not appreciated.
Be nice. Be nice is the bare minimum.
Okay, that's true.
I'm quoting.
I'm talking about inpatient care. I can't be nice to Luke, okay? I can't do it all the time. He's an interesting character. No, it's been a very interesting week for us. We have been through a snowstorm. We have spent large amounts of time at the hospital, and
The beds are like,
yeah,
slept here
yeah.
2 nights.
Definitely. I know how to answer phones, very complicated phone systems, and yeah, I think we've learned a lot. We've basically managed like a mini disaster, like internal local disaster, I guess you might say, where we've had staffing constraints. I think we've learned a lot for sure. Definitely experienced some frustrations. So I think we'll revisit that in a different episode, some of the things we've experienced whenever we've had a little bit of time to process. But today we're in the second part of our series about rapid responses, and our focus is going to be really diving into sepsis and hypovolemia, which are two very critical conditions that all of nursing needs to be able to recognize and act on very quickly. It is one of Luke's favorite topics.
I mean, I would say that this is where nursing, like this is, like the, number one killer worldwide. And when you think about,
for sure, yeah.
Yeah, and when you think about like all of the ways that, people are coming to the hospital already septic or, lines, drains, tubes, surgeries, like the, intubating and all the ways that devices, whatever it is that we have that, can lead to infection. In a germy environment, this is like where the nurse really plays such a vital role in prevention and early identification, because, the earlier we identify, the faster we treat, and, the faster we treat, the better the outcome. I mean, talking about statistics, I'll say this over and over again, but it's like 7.4 or 7.6%. Increased chance of mortality every hour that care is delayed from the identification of like time zero for sepsis.
So that's why we really thought that it was important to have an episode where we were able to focus really on sepsis and some of the hallmark traits, the service criteria, and really spelling it out to you, trying to make it as simple as we can. It's definitely a complicated issue, but yeah. So let's stay caffeinated. Let's stay caffeinated, stay curious, and we'll get rolling. So that quick housekeeping piece we always do. Our disclaimer: the views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational and entertainment purposes only and should not be considered medical advice. All right. So, our first topic is really, what is sepsis? It is, defined as life-threatening organ dysfunction, and it's caused by the body's response to an infection, basically being dysregulated. And so we're going to be focused on the service criteria. There's some other criteria out there for sepsis that they may use at other facilities, but this is the one that we're the most familiar with at this time. So that's what we chose to dig into for y'all. So let's go over the service criteria. What do you? That was.
Yeah, surge criteria is just a systemic inflammatory response process. And so, you're going to have, these are vital signs, essentially, labs. And, so your vital signs are going to be kind of out of whack in the hospital. And it's normal for our bodies to have like a inflammatory response, like when we have a surgery, have an incision, like our body's going to see some of this. But this is where we need to look at, like, sepsis is actually a progression. So SIRS would be like level 1. This is prior to sepsis, and it's going to be like a higher low temp, high respirations, high heart rate, higher low WBC, or less than 32. So, I just kind of look at it, and then like those specifics are like temp greater than 100.4, less than 96.8, greater than normal, right? So greater than 20. Heart rate, pretty much greater than 100. 100, so we're going to say abnormal, but the actual definition is going to be 90. And then an elevated white blood cell count would be like 12,000. So we're, like our body's having like an accurate response and, sending white blood cells to fight infection, or less than 4,000. So it's, the blood cells are getting like bombarded by the infection and not able to keep up. There's also bands. So it's just like a greater than 10% band. So that would be like white blood cell babies. So like production of white blood cells to come and fight infection.
The PaCO2, just for your patients who are being mechanically ventilated, there's also their recovery rate, because we're doing that for those patients. You can look at PaCO2, and it's less than 32 millimeters of mercury.
And I've always just kind of looked at that one as like, well, if they're breathing fast, they're going to be blowing off more CO2, so that number's going to be lower. Someone correct me if I'm wrong, but that's just kind of how I've always memorized that. So SIRS is just, these symptoms. When we get into like the identification of sepsis, so we need 2 SIRS criteria, and then we need a confirmed or suspected source of infection. And the suspected one's always kind of weird, because it's like, what's suspected? Like, I know, like, you come in for a UTI or you come in for pneumonia, but like the suspected is, it can seem vague. This is where we kind of need to be like, well, they came in and they have like a surgical incision, and like, this drainage looks weird, or that incision's like red, or it's inflamed, it's warm. Or
I always think about, the things that we've put in. My first thought is like things we've put in. So any line, especially your central lines, especially your mid lines, not so much. Yeah, I mean, any line we put in can become infected. So obviously, any peripheral IV can. But I think about catheters. Yeah, we think about cauties and CLABSIs, right? Because we talk about those things a lot from
maybe not enough.
Maybe not enough. I mean, never enough. But right, we talk about catheter-associated infections. We talk about central line-associated infections. So those are the big 2 for me. But, anything that we've put in device-wise, I automatically think about that. But then you start looking at, what have we cut on them? Is there...
We're on an event. So
we're on the event.
Are we on an event? So, app and all the new names that they've given, ventilator associated event assembly.
See, I mean, you have to think about, like, we have plenty of people who come in from the community with infections, right? All sorts of infections, but some of the things that we do to try to help people also can cause infections. I mean, we know that, right? So you have to remember those things.
Well, the importance of the bundles.
So 100%, yeah.
Bundles and oral care and subglottic bed and 30 degrees and proton pump inhibitors. Like, those are
mobilizing your patient, getting them up and moving, especially post-surgical, as best you can. Getting people up and moving is really important, and encouraging that. And then those flutter valves,
lung percussion.
There's so many things we can do to help.
Like a lot of students ask them what sepsis is. They say it's an infection in your blood. Like they're kind of like describing bacteremia to me. So that that typically would be a blood infection. This is just an infection in your your body, and yes, it could be related to a UTI, or yes, it could be related to a specific area where we're going to say, oh, it's urosepsis. But this is just something the body's doing there. So, the nurse's role, we've said got these lungs, tubes drained, those are a common culprit. Let's get those out as soon as possible. No matter
identify the source as quickly as you can and as best you can.
But also, like, without those things, we're gonna say that time zero. So yes, we always want prevention. So prevention, very important. Get rid of any of the culprits that you can get rid of. Really good assessment skills, But let's say we can't get rid of a central line. Patients on, multiple strips, it's not a emerald. We would hate that. It's a more optimal central site. We really want to sepsis is really possible. So, we talked about these like smart web crawlers or documentation systems. I our patients to, and any
charge go flat.
Like where it looks at like a positive call that the computer hey, you suspect sepsis, your sepsis.
Those are really helpful. I think especially for people who are coming into, I can't imagine, we've seen the technology evolve into that since we started. I mean, that's when I started, we were paper charting. And so I can't imagine.
Yeah. Paper.
I did not, there wasn't a paper alert, no sticky note came flying at me from across the room. It's very unfortunate.
Absolutely.
That would have been amazing. Yes, I would have loved that. But no, I mean, I can't imagine where technology is going to go.
It's not a fail safe, so
it's not
based on.
You almost get alarm fatigue like you do with a typical audible alarm, where you have so many, especially if you have vitals that are put in incorrectly and stuff like that. But you have to use those resources as best you can.
Yeah, and I mean, we definitely, as an organization, try not to have too many alarms. Like people want to do pop-ups for everything, and I know that they're pretty good at saying, no, we don't want to have, like consistent alarms as an organization. We want them to, people to realize when they get one, it is very important. But we do need to consider like that alarm is going to be triggered from documentation. I'm busy sometimes, and I'm not often, frequently, and not able to document vitals, which are the predominant triggers that are going to stop these alerts. So can't do that. I'm sitting down at 2 o'clock in the morning. And I'm documenting a set of vitals from 7 p.m. This is 7 a.m. Let's say I get a trigger for, hey, this is septic. I not treated that patient for second, or since times of when we noticed or would have received a septic. You really need to, in your mind, know, just on assessment, hey, that's normal breathing, that's like abnormal time, communicating with your tech if they're getting temps, making sure that you're following up on vital signs.
I mean, I think we're understanding of the fact that not every single thing can be charted in real time, but just getting those vitals in, right?
Yeah.
So just getting those vitals in, yeah,
we need
recognizing that, but I think it's really important, especially with vitals, to get those in real time, and that sometimes might be a conversation you need to have with your ancillary staff or students or whoever it is getting the vitals, but making sure that those are put in as quickly as possible is really going to be, truly important, especially when looking at sepsis. But
so we talked about SIRS, and then we've said this is just going to be 2 SIRS criteria plus a confirmed or suspected infection, and like what those suspected infections look like. Urine stinks. Smells weird, cloudy.
Yeah, I mean, you hate to think about it, but that is diagnostic.
We're going up on oxygen requirements, got an x-ray that says, maybe pneumonia, So, we've looked at that. So, like, what about like severe sepsis? So this is where we've got sepsis, we've got signs of end organ damage, we've got hypotension. I think in the hospital setting, we're always going to say systolic blood pressure less than 90. We have a lactic acid that's greater than 4.
Yeah, so that's whenever you're seeing. I mean, you're looking at your renal lab, your kidney labs,
So that would be signs of end organ damage.
BUN and creatinine. We're looking at bilirubin for sure. We're looking at for liver function, of course, and you're really looking for
level of consciousness.
Oh yeah, altered mental status. I'm sorry. Yeah, altered mental status is really helpful, especially when you see people who are hypotensive. Whenever they start getting really low,
is my brain being perfused? So
I mean, you have to think about that.
Oxygen and blood being perfused to the top of my body.
Right. And you start thinking about what you can do about those things. And
well, that hypotension is where that lactic raises. So, we're thinking about, hey, I have a low blood pressure and
you're not perfusing the tissues.
Doing great. So that lactic acid is telling me somewhere in my body is doing a process that it normally does under aerobic. So where it has like blood flow and it has oxygenation, but it's doing it currently under anaerobic conditions. And it's letting off this lactic acid, essentially like, help, restore blood flow.
And that's one way to think about it. I mean, that is the way to think about it. If your lactic acid is going up, it means you have tissues that are not being adequately perfused. So they're producing that lactic acid because they're not getting adequately oxygenated, right? So, and that could be, and that's directly resulted from sepsis and hypovolemia. Take steps. I mean, that's when we have to really jump in and start taking over some of these processes and starting treatments. We do want to look, hypovolemia in particular. We've talked about, systolic less than 90, a MAP of less than 65.
Yeah. Most of us are MAP queens, and like I said, it depends on ICU or what. But MAP less than 65 is telling me a lot about end organ perfusion. So sometimes I feel not as targeted towards the systolic blood pressure. They're like, but 88, So, in my mind, I always kind of think about it as, MAP is systolic plus diastolic times 2, divided by 3. And your true blood pressure is closer to your diastolic pressure, since diastole is twice as long as systole. So, as long as your diastolic is not super low, you can sometimes have a systolic blood pressure that's under 90, your MAP is still over 65. And I can help this patient with it. They're answering questions appropriately. Their cap refill's good. They seem to be perfusing well. Their body is warm. This is just something they did. Now they're a dialysis patient or a liver patient. They take midodrine.
Some people do live low. I mean,
they're a little old lady. It's not. So
their requirement, they're a small person, in body habitus. So they require less. I mean, some people live low. I mean, they may be, an athlete, an elite athlete, and they live low. So these are things that can happen. But we look at the average, and 65 is what most people need to be adequately perfused. But that's also where you're assessing your patient, like he's saying, their color, their mentation, their cap refill. These are all, things that when one of them starts
tools in our toolkit.
Yeah, whenever one of them starts going off, then you start looking at other things. I think mentation is a huge one.
Yeah, he's cold, he's white, he's altered mental status.
Yeah.
Or he's pale, whatever it is.
Well, there's
probably an issue. Yeah,
it's a direct result of poor brain perfusion. So altered mental. I mean, obviously it could be something else, but when you're looking at sepsis or you're looking at hypovolemia, you know that's a problem. You have to consider the.
So how do we treat? So we'll say Um, you need fluids.
Fluids. Yeah, for sure. So we're looking at the treatment of sepsis. We're looking at so we have an algorithm for the treatment of sepsis.
What is it?
When we talk about the golden hour or so, there's different bundles that you need to complete. The golden hour. The biggest thing is 30 milliliters per kg of crystalloids for the hypotension. And if they're not hypotensive, which they probably are, but if they aren't, if you have a lactate greater than equal to 4, you also need to initiate that bolus of fluid. So, and your crystalloids, what does that mean? We use that term. A lot of people don't know what that means. So crystalloid generally refers to your normal saline or your lactated ringers. Is there anything else that falls under crystalloid? I don't think so. Those are the two we're going to give in the hospital setting for sepsis. And then we're also going to start a broad spectrum antibiotic within the first hour.
So yeah, we've measured a lactic. If lactic's greater than 2, we're going to do a lactic with reflex. So we're going to reassess that. If it's greater than 4, then we're going to assume that we're going to start pushing fluids at these patients. So we want blood cultures. We want blood cultures on these patients. What other cultures do we want?
So if you're going to do blood cultures on everyone, but like if you've identified a source of infection, you're going to be culturing that as well. So if it's a central line, then we're going to culture. We're going to be working on removing that central line, and we're going to culture the tip of that central line. If it's
urine culture, sputum culture,
urine cultures as well. Sputum cultures. If you've got a patient that you think it's pneumonia. If you have a patient that has a trach, you might do a trap on those. But anyway, so so a culture of the site. I mean, obviously, if it's a UTI, it's going to be urine. If you've identified that you think it is a UTI, you think it's caused by a catheter, then you're going to be considering what you might need to do to safely remove that catheter as well. And those are all, in some ways, physician-led, in some ways, nursing-led. It depends on your facility policy. So what are we going to do if our patients are hypotensive and it's, dangerously hypotensive? After we give the fluids and they're not responsive, where are we going to go next?
Well, I mean, I think we're going to add vasopressors.
Yeah. All right. So we're looking at vasopressors for the next step. And for your patients you're looking at a map that's less than 65. You don't think they are adequately perfusing. You started your antibiotics. Or maybe you haven't gotten to start your antibiotics yet. I hope you got your cultures before antibiotics. Please always get your cultures before antibiotics. But no, I mean, so we have a patient who's, deteriorating. Their, blood pressure is low. You've determined that it's, critical, and you're making the choice with the physician to start pressors. So that's where we are now.
Then my goal would just be, I've given fluids. I'm trying to put volume in the body, see if the patient's responsive to it. And then I'm going to give the pressors for that squeeze. Hopefully it's going to pick up perfusion. Hopefully it's going to make my blood pressure better. But, my goal would be getting that MAP greater than 65. That's frequently what you're going to see in the hospital setting, MAP greater than 65.
Yeah. So, we have one that we consider first line, and that's Levophed or norepinephrine. We give that, that's our, like I said, our first line, our go-to, and it seems to work better in our septic patients. So we definitely look at that, and we get it started pretty quickly. It is a weight-based dosing. In most places, you're never going to see that outside the ICU. I mean, there are a few situations where some places may give it outside the ICU, but it's not very common at all. And that's going to be something you really need to look into and study. It's not something you're going to give if you're not familiar with it. But definitely weight-based. That's one of the reasons why, there's many reasons why it's important to also wait on your patient. Like for me, when I'm coming in from a rapid response standpoint, I'm definitely going to not want to know your patient's weight. And I'm hopeful that you got one before the deterioration started, because then I just have to guess, which is not as accurate by any means, right? And it's really important for us to know what weight we should be basing our drug calculations on. So, right. So once you've got your blood pressure stabilized, hopefully with your norepinephrine, with your MAP above 65, you've given your first bowl of fluids of 30 mg per kg, and you've maybe gotten a handle on the emergent piece of sepsis. Hopefully, you're going to be definitely looking at repeating your lactate every 2 to 4 hours. Hopefully, seeing it go down, which means the tissues are being better perfused. You're definitely still thinking about, what's causing this. If it's like a surgical site infection, you may be having to coordinate with the OR on when your patient might have to go back. You may be looking at an abscess that needs to be drained. You may be, there's so many things that can cause an infection. So it's hard to know exactly where you're going to go with that. It's all patient specific.
So I think, after we talk about, MAP greater than or equal to 65, we've talked about some of that, septic shock and what it looks like, and how sepsis is a progression of, SIRS, sepsis, septic shock, and it's just adding things each time. We need to look at what the volume issues, so, we have the severe sepsis. So this is, we've got this low MAP, this low systolic blood pressure less than 90, MAP less than 65, whatever criteria you need to utilize for that. But, we need to treat the, supposedly it's refractory, right? So it's refractory to treatment. So we've given volume. We've started, we're starting epinephrine, levothyroxine would be the first answer that we would use. And our goal here is to get that blood pressure up. So some of the reasons why we have a volume issue is there's like an increased capillary permeability when a patient is septic. So we've got like a fluid shift. We've got fluid leak. We need to replenish that fluid.
The fluid is not in the vascular system where it's supposed to be. So the tissues.
We're going to replenish it. That's that 30 mils per kilogram that we're giving the patient. And then we're going to start the vasopressor to work on that squeeze. So that squeeze down. But, there's got to be something in the blood vessel to squeeze down on. This is why sometimes you'll hear people, I just keep going up on vasopressors, and nothing's happening. And those people often need volume, because we can continue to squeeze down on a blood vessel, but if there's nothing in there, it's not going to increase the blood pressure. We're just going to see high levels.
But, you can only give so much crystalloid. I mean, you have to replace what they're losing. And what they're losing is...
So that volume issue look like? So like on assessment, so yes, we want to restore perfusion, and yes, we want to get good perfusion to the kidneys and the brain, all of the, the organs. So, we don't damage them further. We don't progress them to a multi-organ problem where we have damage, throughout the body. That's going to be really hard to come back from. But like when we're assessing perfusion, what does that look like? So we can see the map on the computer, and we can say, hey, that's a pretty good indicator of end organ perfusion.
Very much.
Not 11 to 65, but what does that like skin assessment look like?
So if you're wanting them to have, be pinkish, if you're
they pale,
if they're pale, that's bad. I don't want them to look, pale white or gray or.
So is the cap refill like So like we're looking at refill. It's telling about we're filling the skin. Is it cool or is it, form they're using? So we look at these numbers and we say like 65, generally a good number, right? 65 might look different
for different patients. Yeah, for sure.
I think usually it's pretty good, but you might actually see where some people we say, hey, 60 is good for this person. So we need to realize in general numbers are generally some variances based on size or just based on a patient's other factors going on with the patient. I think another thing with fusion is I've always been told that what is it like 30 cc's urine out.
You see adequate kidney perfusion that way. Yeah, absolutely.
That's
good
like
point. Yeah,
saying the patient's got a Foley or you're doing strict eyes and nose if they're using a potty hat. No, but the test question once and it was like less than 30 cc's per hour, or you have to have at least 30 cc's per hour. And then like the actual answer on the test is like 300 mils shift. And I was like, but a shift's 4 hours. Like minimum would be 360. I mean, I still think about.
Oh, I'm sure you were such a fun person to teach. You're questioning the test questions and the exam, and trying to get points after the fact.
Seek to understand. No, I think the current research actually says that you can identify kidney injury at less than 0.5 mils per kilogram, but acute kidney injury. So if a patient's 100 kilograms, they should be making 50 mils of urine an hour. And yet, maybe look at and we've got patients that's on fluids. It's not on fluids,
It can look different if your patient's fluid restricted, but then if you have them on Lasix, it's hard to really assess exactly how much you're going to be getting out.
Like something you should consider.
No, I mean, I think 30 is probably the minimum for most people.
I still think they're teaching 30 in school. The research that I've read years ago, actually 0.5 mils per kilogram. I think they teach them together, test wise. Just remember 30. The reason nurses need to know up to date research was taught 13, 14, 15 years ago.
Everything's constantly changing, looking at, better ways to assess patients. So as we get closer to, the end, we definitely want to look at some common pitfalls and also just like tips for, how to move forward, things we maybe haven't covered.
I mean, that tip is early intervention. The tip is
prevention.
While it's easy to have a catheter, can we are they really no pressure or even eligible? Or if they're not, we can probably remove sessions with providers and team every single day and getting central lines out and getting catheters out and what systems are looking like, making sure that you notify it's named and
some places have nurse-driven policies for this, so you can be a really active part in pushing getting these lines and these Foleys out. So you have a lot of ability to advocate for your patients in that way.
So then,
also just using like proper sterile technique when you're putting in things. I mean, especially Foleys. Nurses put in Foleys. If you're putting in a Foley, please make sure that you're going through the proper steps, using your hand hygiene and every single step of the process.
Cleaning it daily.
Oh, yes, please. Yes, for sure.
Zillion things that we can do on the nursing end to prevent infection, minimize infection.
Oh, yeah.
So, it's really important for prevention, but also, moving can we benefit?
No.
I don't it is, in our will straighten also infection is going to happen, but early intervention, just knowing in your mind, okay, I'm not maybe able to document it in real time or like backup where there's a sepsis crawler that's going to be able to tell me because I'm not touching them. But look what's prior to patients having discussion about lab and like if your patient's breathing, they're knowing those signs and symptoms of sepsis and what their risk factor would be like they have us fully at a recent surgery. So we can start that conversation immediately with the providers, get the cultures, get the antibiotics, get the labs, and start treating as soon as possible.
Don't delay your antibiotics, especially not for results. I mean, we definitely need to get cultures before we start our antibiotics, but that's your antibiotics are going to be what really treats the cause. So getting those on board as quickly as possible is huge.
They are a lot of lactic acid, such as always associate that lactic acid with a measure of perfusion and oxygen delivery.
Don't underestimate the importance of getting that fluid on board as well and doing fluid resuscitation. And that's huge in getting that lactic down. That's huge in restoring perfusion. And then, make sure you're also like reassessing the interventions that you've got in place. See what else can be done and having, open dialogue with your provider. So as far as like, I think we've kind of touched on this, but just a few pearls of wisdom when it comes to sepsis is, or just a few of these can help with anything for sure. Making sure you're trying to recognize even subtle changes in your patient's condition. It's hard when we get bogged down with all the tasks that we have to complete, but trying to even recognize little things can make a huge difference. Whenever you're calling your providers, we've spoken about this multiple times on other episodes, but making sure you have all your data in front of you as best you can using that SBAR format. That's going to tell your provider that you're prepared, you know what's going on, and it's going to keep you from kind of being blown off. If you go to your provider unprepared, sometimes you're not going to get the most positive interaction. So, and then also like discuss with the families of the patient, like anybody that's there that's supporting them, like giving them some as best you can, explaining what's going on and helping them understand the urgency of sepsis care. We sometimes neglect.
Like is that like hey, we want to make sure that we're cleaning off this catheter really well, and this is the reason why we have to have the catheter. But the second we turn X off, this strip, whatever, we're going to get that out of there. Hey, we want to make sure that we're cleaning the central line and we're doing really good hygiene, really good oral care on this patient and suctioning.
Yeah, I think it's
having those
discussions. I think it's important to have discussions with family. If you're fortunate enough to have family who want to be involved in someone's care, they can be very helpful if you take a moment to give them that education. I mean, that can be helpful for you as a nurse, but it's also going to be helpful for the patient when they go home. This person's involved in their care. It's also going to make them feel more normal, So I think if we take a moment and give some priority to that little spot of education, it can go a long way for the patient. So we did want to talk about kind of the impact of sepsis. Luke and I have discussed prior to starting this podcast about we see sepsis every day, and unfortunately, we see patients die of sepsis. It's we said the number one killer
in the world.
Yeah, I mean, so we did want to talk about just kind of like the importance of or the gravity of this situation. I guess is recognizing sepsis and moving forward on it, because we want to see you be successful and we want to see that those positive patient outcomes for you. You're never going to win everyone, right? So you're going to have patients who, maybe they come in and they're already septic and we're already behind the 8 ball and they've they've delayed coming in and seeking care for one reason or another. And so you try everything you can, and even our best is not enough. And you have to recognize that that's always a possibility. You lean on each other whenever you see those kind of situations, or you can become emotionally affected by these things.
What about I walk into another nurse's room to help them turn a patient, and I notice that patient's on the vent, subglottic's not hooked up. What's my role in that?
Well, I think if you see something, say something.
Say something.
I mean, that's always.
I was like, do you want me to hook that up for you?
Uh-huh. In the nicest way possible.
Did you not already just say, it's actually, I've got it. Like, let me go get some. Let me go get some suction tubing for you in a canister.
And that's a good rule of thumb. No matter what you're doing, if you see something and it's not right, absolutely say something, because it can make all the difference in a patient outcome.
I mean, these conversations that we're having at bedside every day.
Well, and we're a team.
So,
yeah.
Do I have the ventilator bundle met? Can I get this catheter out?
Yeah.
Why is the central line placed there? It needs to be moved. It can't be in the groin, femoral, whatever.
Right.
So those are great times to have these conversations. But there's also it is okay for me to kind of like a peer review. You are my peer. Hey, like this is the standard we need to meet. It's really important. Maybe you didn't notice it. It's early in your shift. Let's get this section hooked up. Let's get this subglottic section hooked up. Something you should be checking at bedside shift change when you're doing report, making sure that you've got all of those measures in place, to protect your patients. Make sure that we're not making them sicker. We want to come to the hospital to get better, not worse. Would be, for sure unfortunate. I think, creating peer accountability is empowering. I don't see, this nurse is always picking on me. So this nurse expects me to do what's right, and knows that I got into nursing because I care about, people getting better. No one wants to hurt anyone.
No, we don't want to hurt anyone, and we respect each other as teammates, as coworkers, and as professionals. And I think, if you see something that's not right, I know I'm somebody, I can't walk away, right? We know that about me as a person, right? If I see something that's not correct,
I fixate.
Yeah, right.
I fixate. That's all I can think about.
I can't even.
You're giving me a report, and I'm just staring at the whatever it is. But I'm like, okay, it's okay, Rob.
And we can, as team members, as teammates, we can absolutely take a moment to speak up and even gently educate. I love educating. I love teaching, which is
some of it's never received well to where they actually do it and learn from it, as if it's gentle.
Right. If you come at somebody harsh, you're not going to get.
You're not going to fix the problem. You're going to maybe fix it.
You're going to create conflict. But approaching someone, don't be a good teammate, right? So you give positive but constructive criticism, right? So a takeaway for this episode is sepsis is an emergency and time is tissue. Every delay has consequences. So definitely wanted to reinforce that. I think we've touched on all those topics, but we definitely wanted to reinforce that. So last thing, our tip for new grads, always assess perfusion status. So check your cap refill, check your tip, skin temp, and then a mental status alongside your vitals. So those clues can help you detect shock before it becomes critical. Okay. So a couple things we'll do before we wrap up really quick. Got to talk about our merch store. Still really excited about that. We've had a few orders now. It's really exciting whenever people are buying things that you've created. So we would love to see you out and about wearing some Code Brew stuff. So check out codebrewpodcast.myshopify.com. It's also on our socials. And, we've got our logo on several things. I know the mugs seem to be popular, the coffee mugs. And since we're in a snowstorm, if you need a beanie hat, I know where you can get one. Okay. Since we have more snow coming this weekend, so here's a shameless plug. Go get a beanie hat, long sleeve tee, a hoodie. If you need a hoodie, I know where you can get one. But yeah, for those of us, those people here local, please stay warm and stay safe and all that. So as far as what we have coming up, so next episode 7, we are looking at stroke and neuro changes, and then the things that, mimic stroke. So we'll hit a couple other topics. We'll probably hit some liver stuff too. We love liver stuff. And I have to tell y'all, as we've been doing this, yes, we love liver. And I have to tell y'all, as we've been doing this episode, Lucas had the biggest smile on his face because he absolutely loves sepsis, So he's done a lot of research and wanting to make sure we get the most accurate information. So we're really enjoying this, and we're happy to be here and getting this content out to you. I think that's all for us today. As always, stay caffeinated, stay curious, and we'll see you next time on Code Brew.